I'm a cardiac surgeon, and to carry forward the physician jokes, our joke is always we're often wrong, but never in doubt, and that's usually the way that I approach life, right? So Stan had asked me to kind of also think about global innovation and the need for global innovation. And so in that aspect, in my personal intersection of that aspect, I was reminded by William Osler's kind of famous quote that the tragedies of life are largely arterial. And in being a cardiac surgeon, that's always been true for me, right? So if there's a trauma of something and nobody else is able to control it, they call me, I put them on bypass, and we're able to fix it. And if you kind of look at health tragedies, traumas, whatever, it usually relates to some sort of arterial structure. And that is more true in under-resourced areas and areas where healthcare is not accessible to patients and to people to kind of live their lives. And so that's really what I want to kind of spend time talking about, is not only just thoracic aortic aneurysms, but how the way that we treat them now makes them really inaccessible to most of the world's population, and why people are dying from this disease and perhaps could not be. And a little bit of, I think it's always easy to talk about science, right, and keep it dry, but I think a way that people remember it is by perhaps remembering a personal story of the person presenting that information. So I was born in Hyderabad, India, and we had a lot of family issues with cardiovascular disease. And one very specifically, my mother's side of the family, my grandfather and his 5 brothers and sisters all had aortic valve stenosis. Because I'm a cardiac surgeon in the United States, my grandpa got TAVR and is living, and he's 86 and he's doing really great. His younger brother, who is 75, had aortic valve stenosis and was told by surgeons in India they couldn't operate because he was too high risk of a candidate, and he just died 3 months ago. And he's the younger brother of my grandfather. So I've personally experienced how health equity can be presented even in the same family, depending on where you get your care and how close you are to what hospital. And this was really driven home for me. I was lucky enough to train at Mayo Clinic in Rochester, Minnesota, which is where people, I think, flock to, right? Destination medical center. People come there when they want the best care possible. And people showed up. The clinicians there felt that mission, understood that that's why people were coming there, and did everything they could to show up for their patients. But more importantly, the resources that are available at that institution were set up for that kind of care. And so I went from Rochester, Minnesota to about 3.5 hours west to Sioux Falls, South Dakota for my very first job as a practicing cardiac surgeon. And it was a standalone hospital, 54 beds, 3 cardiac surgeons, 40 cardiologists, incredibly technically gifted clinicians that could really get themselves out of any operation. I would say they were better surgeons than I saw at Mayo Clinic. But they would turn down patients because they knew they couldn't get through that patient, through an operation at that hospital. We had 1 pack of platelets on standby, and you can't do a lot of cardiac surgical operations with not a lot of other resources available to you. And so this kind of experience really colored how I viewed patient care. So it's not just about what's written in a textbook, what's written in a guideline, but to a clinician, what can you do with the resources available to you to safely get a patient through an operation? So all of that to maybe say, this is what I want to talk to you about. I think before I can say anything else, I do have to introduce a little bit of anatomy and pathophysiology about aortic aneurysms and dissections. I'll have to tell you a little bit about how we currently treat aortic aneurysms and dissections, and then I would a little bit of self-service about talking about this ELICA device that we're helping to develop and the potential impact of this, I think, on a global level for me, which is really where it hits home. So if you think about the aorta. So the aorta is the biggest blood vessel in the body. It provides the blood flow to every single organ in the body. So it provides blood flow to the heart, to the brain, to the kidneys, and everything else. And it's actually a very miraculous organ, right? So the heart gets all of the limelight, but it can pump while it delivers. And it's probably the most crucial organ in the body that isn't even considered to be an organ. And the wall of the aorta itself is very complex. So there's 3 different layers to the aorta. There's the intima, which is the inner layer, the media, which is the middle layer and the strongest layer, and then the outside is the adventitia. And what can happen to the aorta, because it's a pulsatile organ that sees a lot of pressure, right? We've heard about hypertension, and hypertension is the nemesis of the aorta. And seeing all of that afterload, what can happen is the aortic wall can dilate over time, and just like a balloon, as it gets bigger, the wall gets thinner. And you can imagine with 5 liters a minute going through that, what the implications are if there's a tear or what we call a dissection. It's incredibly life-threatening. And so how do we kind of prevent rupture or dissection from happening is by essentially cutting out that portion of the aorta and replacing it with woven graft. And that's called an aortic replacement, or in the part of the aorta that's called the aortic arch, it's called an aortic arch replacement. And so this is data from the Society of Thoracic Surgeons national database looking at national operative mortality of aortic procedures. So it's a 9% mortality compared to 1% for all other cardiac surgery. It is by far the highest risk operation that we do as cardiac surgeons. So if you can imagine you're a patient sitting in front of me and I say, you have an aortic aneurysm, you don't know about it, it probably doesn't cause you any issues, it could rupture or dissect and take your life in the future, but if we operate on you now, there's a 9% chance I'm going to kill you on the operating room table, an 8% chance that you're going to have a risk, or a 6% chance that you're going to go into kidney failure and have dialysis. I can't imagine any of you are going to sign up for that. I mean, I'm not sure that I would. And what happens is surgeons that don't do this every single day, which in Sioux Falls, South Dakota, you don't do this every day, then you are not offering this operation to patients because you don't feel comfortable with neither your skill level, right, from volume, or the resources that you have at your hospital to safely get a patient through a preventative elective operation. But if you don't operate, what happens is either that wall just bursts and you rupture, or you can have an aortic dissection, which is a tear in that aortic wall. And so blood flows not only just down the tube of the aorta, but it flows into the wall of the aorta itself. And the pressure of it pushes kind of what we call the true luminant. So every single organ in your body doesn't get the blood flow that it needs. So this acts like a heart attack, acts like a stroke, acts like renal failure. And what that means is people don't do well. So it's an 80% out of hospital mortality. So you have a 20% chance of making it to a hospital. If you make it to the operating room in a hospital, you have a 20 to 25% chance of dying on the operating room table. And if you're lucky enough to beat those odds, you have a 10-year survival of 50%. So, I mean, that's a rock and a hard place, right? And that is why the tragedies of life are arterial. And I think we've heard a lot today of how prevention is the best medicine. And so in this case, the prevention is not, some minimally invasive option. It's not a pill. It's that open heart operation that replaces an aortic aneurysm before it becomes an aortic dissection. But we have to make the odds better than 9% chance of dying from an elective operation. And how do we do that? Where do we innovate? And to understand that, I think you have to understand a little bit of how we do the current operation for aortic arch replacement. So we put a patient on cardiopulmonary bypass, which is pretty standard for all heart procedures. But we use that bypass machine in this case in order to cool down the patient to 18 degrees Celsius. So that takes about 45 minutes on bypass. And then we literally stop all the blood flow in the body. So a patient's brain and other organs get no blood flow for 20 to 90 minutes while we take out and replace this portion of the aorta. And then we put them back on bypass, start blood flow, and rewarm them to normothermia. And that takes about 2.5 hours. So now that I've done this operation, it's taken 8 to 10 hours. 4 hours of which has been spent really just cooling and rewarming to set up for 20 to 90 minutes of complete time with no blood flow. So you can imagine from this operation why there's a 9% operative mortality and why a patient's body doesn't accept that. So what can we do differently? I mean, it's pretty easy to, you can probably look from there and say we should probably get blood flow to the body the entire time. And we should probably not cool them down to 18 degrees and rewarm them. But how can we do that? The main constraint here is that the descending aorta, which is the lower part of the candy cane, can't be accessed for me to put a clamp on it to provide blood flow and stop blood flow from being in my face. And that's really where the ELICA device, which we've been working on developing, comes in. It's really a pretty simple solution. It's a bypass shunt that allows for blood from the cardiopulmonary bypass machine to go to the rest of the body and the brain, but uses endovascular balloons in order to stop blood flow from getting into the aortic arch. So now a surgeon can do whatever operation he or she thinks is relevant for the patient, but can do so while providing blood flow the entire time. So now, because we've taken away the need to cool and rewarm the body, we've decreased operative time by 3 to 4 hours. So if there's one thing in the cardiac surgical literature that's been kind of proven time and time again, it's that if you reduce cardiopulmonary bypass time, you reduce morbidity and mortality. And I think it also makes common sense that that would be true. So the benefits of the ELICA device, right, in the short term are kind of lower operative mortality, lower complications, and less resources needed to do the operation. And that's great for every place, right? Like Mayo Clinic, Cleveland Clinic, that's great. But midterm, right, that more elective aortic aneurysm operations are done, like in Sioux Falls, South Dakota, right? Because you now don't need the same resources that you needed with deep hypothermic circulatory arrest. And thus there's better access to care. And long term is really where we get to the prevention part of this. There's not a single screening program for ascending aortic aneurysms. This is something that is almost fatal, right? 80% out of hospital mortality, and we don't screen for it. Why is that? We don't screen for it because the treatment for it is not great. So if we can make that treatment better, we can screen and prevent those deaths. So this was supposed to animate a little bit, but essentially what the ELICA device does is give that blood supply to the brain and the body, drastically shorter time on cardiopulmonary bypass. We aren't at clinical studies yet, but what we do have is surgeons have been so desperate To innovate in this space, we've used off-label devices to do essentially the same thing that the Elica device does. And you can see kind of some of the diagrams here. In the middle picture, basically a surgeon has found every single place to cut down on the body to provide blood flow to those areas, which takes about 3 to 4 hours to set up and using off-label devices. And in the last picture here, somebody's using an endotracheal tube or a breathing tube in the aorta with the cardiopulmonary bypass machine as an off-label. So if people are taking that kind of medical legal risk, it's really because of desperate situations. And so I think to kind of bring it back to the topic at hand, which is global healthcare innovation, so in India, just because of my personal experience, they do the largest number of coronary artery bypass grafting in the world. They do the fewest aortic arch operations in the world, not because the patient burden doesn't exist, but the resources don't exist to do those operations. And the quality of life that comes from that for the entire patient economy is huge. So in summary, we really need to make aortic arch operations safer so that it allows surgeons easier access to offer them. And that means more access to care, which ultimately means less deaths globally.